Welcome to part B of seminar 4 on addiction. This seminar talks about specific substances of addiction, and under part B we're looking at alcohol. So in this section we're looking at alcohol. Why do we drink? Why does mankind drink? What is the problem with drinking? How much is okay? And what sort of treatments are available? So what are the effects of alcohol on the brain, and why do we use it? It reduces the arousal of our brain, and particularly the smart brain or frontal lobe, and therefore we do less thinking and less worrying in general. We become less inhibited, and this allows us to become less anxious socially. There's less control of our behaviour. Alcohol also produces an endorphin release, which is an opiate-like chemical in our brain, and this gives rise to pleasure. It also helps to manage our emotional, physical pain. It also has an effect on physical coordination, which you would have observed in people who are drunk. But overall, we drink for pleasure and social and cultural reasons, for self-medication, and sometimes due to addiction or dependence. The bad news, unfortunately, is that alcohol is a toxin, and it can affect the brain, the liver. It's the leading factor in death of men in terms of risk factors for death in men aged 15 to 59. That's basically adult males. It represents the 4% of the burden of disease worldwide and 4% of the deaths worldwide. And it affects around about 10% of adults, males more than females. This is a list of conditions caused by alcohol which result in disease or disability as opposed to death. That'll be in the next slide. And these disease states include brain damage, which is direct effect of toxicity of alcohol, unintentional injuries, intentional injuries, liver cirrhosis, cancer, cardiovascular disease and diabetes, and prematurity, low birth weight, and fetal alcohol syndrome. These contribute to something like 4% of the burden of disability worldwide. This is a slide similar to the last one, but looking at deaths resulting from alcohol use. At the top of the list is unintentional injuries, which you'd expect from intoxication episodes resulting in falls, injuries from car accidents and fights. Then, surprisingly, cancer is the second most common cause of death from alcohol, followed by cirrhosis of the liver, cardiovascular disease and diabetes, intentional injuries from disinhibition of behaviour, brain damage, and then prematurity. So how much alcohol is considered an acceptable risk? We've seen in the previous slide that alcohol intake is associated with a variety of diseases. Large studies of risks using insurance data have come up with these sort of figures, which show that to stay below a roughly 1 in 100 risk, one needs to drink less than 2 standard drinks per day. 1 in 100 risk is actually a lower risk than, say, the risk of dying in a motor vehicle accident. So this is the sort of benchmark that has been set for the risk of alcohol-related disease. So let's look at the effects of alcohol intoxication on the body and the effects at various levels of alcohol in the blood. The number of drinks that against each alcohol level is worked out on the basis of a 60-kilogram female, an example of someone who might be drinking as a teenager. So if one was to have a blood alcohol level less than 0.05%, which is the prescribed limit for a black P plate holder, that would result in no intoxication to any extent. That would be the same as having approximately 1 cruiser in the first hour of drinking. A cruiser is a premixed spirits drink with 1.3 standard drinks. If one was to keep drinking, say, a 4-pack of cruisers over a 4-hour period, that would result in 5 standard drinks, which would be a blood level of 0.06, and that would result in the appearance of being tipsy, that is euphoric with a bit of loss of inhibition, appearance appearing more friendly and talkative, but some impaired motor skills, therefore not capable of driving. If one was to drink that same 4-pack of cruisers over a 2-hour period, or possibly have 4 glasses of restaurant serves of wine, it would result in a blood alcohol level of 0.13. In that range, one would be visibly drunk. They would be excited. Their judgment would be severely impaired, as would their walking. They would be staggering and have slurred speech. In the situation of a person having, say, 6 cans of either beer or premixed spirits over a 4-hour period, that is 10 standard drinks, and one has to look at what a particular alcohol level is in some premixed spirits, but that would result in a blood alcohol level of 0.2%. At this level, a person is very confused, and they actually need looking after because of the high risk that confused state presents. They may end up getting lost on the way home, falling over and hitting their head. They would be very sleepy. They wouldn't be able to walk very well without help, and they would probably be incontinent of urine. A situation that might present is when teens are experimenting with alcohol and may drink half a bottle of vodka, not realising how much alcohol is in that. Just say they drank half a bottle of vodka over 5 hours, that would result in an extremely high level of alcohol where the person would be virtually unconscious and at the risk of choking because of loss of protective reflexes in their throat. This is a situation where the person would need to be rolled on their side and left in that recovery position, but certainly to call an ambulance to take them to hospital. If a person was to drink a whole bottle of vodka, say over an 8-hour period, that would result in a potentially fatal level of alcohol in the blood. And unfortunately, this does happen occasionally with teenagers who consume large amounts of spirits, not realising the toxicity of that drink. Now, also remember too, while we're on this subject, that the body can only metabolise alcohol at the rate of 1 standard drink per hour, and in females and small people that may be actually less. So in answer to the question, how much could I safely drink on one occasion? It does depend on the number of drinks overall, the rate at which you drink, that is if you're drinking more than 1 standard drink per hour, which is the rate at which your body can metabolise alcohol, ideally, being female, which also reduces the rate at which you can drink, being of low body weight, having an empty stomach, which promotes rapid absorption of alcohol, drinking concentrated alcohol, such as in the form of spirits, like shots or fortified wine. Wine itself is stronger than beer. Taking sedative medications at the same time as drinking will increase the effect of alcohol. And one needs to think about the rate at which you will metabolise and therefore whether you'd be safe to drive the next morning. The government guidelines recommend the maximum of 4 standard drinks on any one occasion, and in view of the larger than 1 standard drink serves, that may be as few as 2 or 3 serves of alcohol on any one occasion. This is a list of criteria used to diagnose addiction as applied to alcohol use disorder. The 3 headings are the loss of control, objective problems arising from the alcohol use, and subjective symptoms of craving, tolerance and withdrawal. A person only needs 2 criteria to be diagnosed with an alcohol use disorder, and the more criteria, the more severe the disorder is. So under control, attempts to cut down have failed. Using larger amounts than intended or for longer periods than intended, that is, once when one goes to have a drink, they end up having a lot more than intended. The use of alcohol despite hazardous or prohibited situations such as driving or at work. Use despite knowing the harms, that is, a person is aware of those harms, physical and psychosocial, but they still continue to drink hazardously. Use despite recurring social and psychological problems, that is, the person has experienced embarrassment as a result of their drinking and they still continue to drink excessively. Objective problems as applying to work, social and family activities are reduced. There is also repeated failures in responsibilities in those areas. And spending a large amount of time drinking and recovering is also an objectively verifiable problem. Then the subjective symptoms of craving, the tolerance, that is, a person can drink quite a lot before becoming intoxicated. And then in some cases, particularly in older people who've been drinking for 20 years, for example, they may experience some withdrawal symptoms such as tremulousness, anxiety during withdrawal. We'll go on to look at the withdrawal syndrome in more detail later. This is a list of risk factors that will tend to promote alcoholism or alcohol use disorder. A strong one is family history. If there's a strong family history, then one should be very careful about how they use alcohol and at the age at which they start drinking. An early onset of drinking is strongly associated with increased risk of developing alcoholism. Because the frontal lobe, or our smart brain, is what gives us the ability to control our behaviour, anything that interferes with the development of the smart brain is likely to make us more vulnerable to substance use, including alcohol use, such as developmental hurdles such as ADHD, severe mental health disorders of childhood, anxiety, trauma, and even physical head trauma can increase our risk and vulnerability. Mental health issues for similar reasons, and possibly because of the emotional pain driving substance use. The ability to obtain alcohol or substances is also a factor in how common alcoholism is. So we have laws and taxation around alcohol, and which reduces the exposure of people to alcohol. And then the family and cultural norms, both in a positive or a negative way, can affect our alcohol use. Looking at alcohol withdrawal. Alcohol withdrawal can be anything from a mild syndrome or almost unnoticeable through to severe and life-threatening syndrome. And there are various risk factors that affect how an alcohol withdrawal will pan out. Obviously, long-term heavy drinkers have a much higher level of tolerance and therefore will develop a more severe withdrawal, and a history of previous withdrawal issues, past seizures or brain injury, people who drink more than 8 standard drinks a day, people who are older and frail, people with medical problems such as liver or lungs, those who are poorly nourished, those taking other sedatives, all have high risks of developing a more severe withdrawal, a more complicated withdrawal. And essentially there is, the syndrome tends to follow, if you like, the opposite effects of alcohol. Alcohol being a sedative, the withdrawal is a state of agitation, anxiety with tremor. But also the body is under severe metabolic stress, and there is also fast heart rate, high blood pressure, possibly raised temperature. Alcohol withdrawal is often missed in the early stages and can progress to a severe state during which the brain is under extreme metabolic stress, and this can sometimes lead to a delirium called delirium tremens. This is a state of severe confusion and extreme stress on the body. This can actually be fatal if not managed correctly. A withdrawal can be prevented by the timely use of diazepam, and particularly in the early stages, particularly using a monitoring scale which picks up signs of alcohol withdrawal early. Seizures can be an unexpected occurrence in the first 48 hours also. We'll go on to look at where alcohol withdrawal should occur. So where should an arranged alcohol withdrawal take place? Well, certainly for high risk withdrawals, it should take place in a medically supervised setting, such as a hospital or a dedicated withdrawal unit. This can be pre-arranged through drug and alcohol intake through your local health district. It often takes some weeks to arrange, and it's important not to stop drinking until the admission is imminent, that is within, say, 12 hours of admission. But many low-risk situations can be managed in the community. Most GPs can advise on whether withdrawal in the community is suitable and can manage it if they have the sufficient skills. Diazepam or Valium is dispensed daily from a community pharmacy under supervision for around 3 days, and clear instructions need to be made by the GP and a competent carer present to observe the person closely, with attention to their state of hydration and taking a vitamin B1, which simply prevents any excessive stress on the brain's metabolism. But for any further advice, call the drug and alcohol intake line, and this number here is the one for the Hunter New England Local Health District, 1300 660 059. So following alcohol withdrawal comes the relapse prevention phase. Much of this has been covered in Seminar 3, and you'd be familiar with the cycle of recovery, and that recovery often involves a number of attempts at achieving abstinence, involves a lot of input from family and friends, as well as a psychologist, recovery groups. In some cases, more intensive interventions required through residential rehab, and if someone has insurance, then day programs may be useful. But medications can be prescribed through any general practitioner, and there are 3 that are useful for alcohol relapse prevention. The first is naltrexone, which is an endorphin blocking drug. It tends to reduce craving by reducing the pleasurable experience of drinking and thinking about drinking. So it reduces the craving before someone starts drinking. It tends to reduce the size of binges, and so it is useful for people who are continuing to drink but trying to cut down. Acamprosate, on the other hand, is one that is it balances the brain chemicals after a person has stopped a period of heavy drinking, and it reduces craving by increasing the relaxing chemicals of the brain, which have been reduced by the presence of alcohol. The third medication is antabuse or disulfiram. This medication is often used as a last resort because it is expensive. It requires supervision for someone to take it, but it causes severe nausea and flushing and quite a lot of stress on the body in the presence of alcohol. So it's an aversive medication. It's useful if it's a last-ditch effort to stop drinking. For example, if someone is an airline pilot and they need to absolutely never drink again to keep their license. It's a very useful medication when it's used properly. It generally works better in groups where there's the support as well as the supervised taking a medication at least once a week. But I refer you back to Talk 3, which has the principles of relapse prevention and includes the family training aspects, which is important for family and friends to get their head around in supporting their loved one in recovery. This is the end of Part B of Talk 4 on addiction about specific substances. The next section is on sleeping pills, benzos, and cannabis.